Welcome to the Aesthetics Today podcast, the premier platform where we explore the ever-evolving landscape of aesthetic treatments, regenerative medicine, and cutting-edge beauty products and technology.
Hi, welcome to the Aesthetics Today podcast. I'm your host, Gabrielle Richens, and before we dive into today's episode, a note of thanks to our sponsor. This episode is brought to you by Digital Aesthetics, the UK's foremost specialist agency in health and beauty clinics. Today, I'm joined by one of London's most respected names in medical aesthetics. With a foundation in hospital medicine spanning emergency care, oncology and psychiatry, Dr Zunaid Alli brings a level of clinical depth to aesthetics that's rarely seen. Medically trained in South Africa, he holds a Bachelor of Medicine and Surgery, along with a Bachelor of Science with Honours and an MBA, and later completed a Master's in Minimally Invasive Aesthetics at UCL. Placing him firmly at the sharp end of evidence-based aesthetic medicine. As founder and medical director of Edition Clinic in Wimbledon, London, Dr. Zunaid delivers advanced injectable and regenerative treatments grounded in safety, precision, and full face assessment. Along with his clinical work, he's an educator and trainer, mentoring medical professionals in cosmetic procedures. He also serves as an international key opinion leader for aesthetic brands and technologies, shaping not only patient outcomes, but the next generation of practitioners. In short, he represents the shift from beauty-led treatments to medically-led regenerative aesthetics. And today we're unpacking what's driving that change. Welcome to the show, Zunaid.
Thank you so much, Gabrielle.
Now, thank you for joining me. You're very busy at the moment with your launch on tour with Vivacy and Rejuran, which we're going to get into because polynucleotides is such a massive topic at the moment. So let's start at the beginning though. Take us back. How did you go from hospital medicine, ER, oncology to aesthetics?
So before I moved to the UK, I actually did a GP maternity locum cover.
Right.
I had written all my British exams. I was waiting for my registration and then waiting to move to the UK. So why am I in the UK? The things we do for love.
You have an English husband.
Yes, I have an English husband, yes. So we decided, let's just live in the same city, in the same house, in the same country, because we did long distance. You were doing long distance. Yeah. Anyway, so I did this maternity locum cover, and she said, well, you're going to have to do some Botox and filler because I have patients who have it done. And I said, not really interested, if I'm honest.
Really?
Because she was procedural, so she did minor surgeries and she was also dispensing. GP practices are slightly different in South Africa, so you get GP practices where you get your medication,
right?
It was a really busy practice, but you also
did
GP
procedures. That's doing injectables.
Yeah, injectables, wow. And they were dispensing medication, and so it was really busy practice. And she said, okay, fine, I'll meet you halfway. I'll pay for one of the courses, you pay for the other. And I was like, okay, fine, that sounds reasonable. And then I started doing it. It was really, really good. And I thought, this is quite interesting. And it was still in its infancy in South Africa. And it had started...
Injectables?
Injectables.
Aesthetics, right.
Yeah, this was, 13, 14 years ago? And then it was gaining momentum. It was kind of in the West, like in Europe and in the States. Yeah. People were like, the craze was really starting. And then moved over to the UK, and I was going to be incredibly like a hardcore NHS, like specialized, no time for this, finish CT and then do my ST, CCT at the end, PhD, that was all mapped out, no time to play around. And then it was actually my husband who was like, the girls in my office have it done. Like, if you do it, they'll come to you. And I was like, oh, okay, let's see. So, so that's kind of like how it started, as it does for a lot of practitioners in the UK. Yeah. It's an add-on, or it becomes like a side hustle. Yeah. And then,
that's how it is for a lot of dentists and nurses.
Yes, absolutely. And then I think people just kind of really like what it does and what it's capable of doing, and how it's evolved. So I think that's kind of like what locks them in.
Yeah. And how would you describe your approach to aesthetics that's different from maybe other people and practitioners and clinics?
It's kind of, you've got to have your clinical hat on at all times. So when a patient comes in for a consultation, let the patient lead. When you look in the mirror, what would you like to improve, or what's bothering you, or that's kind of how you start the foundation, how you start to pack it out for the patient.
So tapping into their yeah.
And along with that, you find that patients would, they feel that they might be ready to dabble, or they might just be interested in what you have to say, not necessarily have a treatment. And that's absolutely fine, because the amount of information which we spoke about, the amount of information in aesthetic medicine is completely overwhelming.
Yeah.
And, that's for us. And we've got to kind of really sit and sift through everything. For patients, it's even worse. So it's really starting with the thing that bothers the patient the most.
Yes.
And then kind of working from there in a holistic fashion.
Yeah. Now, let's get into patient psychology and expectations. You worked in psychiatry in your early career.
Yes.
Tell me a bit about that. Was that a lot or just a small part of...
So actually did a qualification in clinical psychology and did medicine to be a psychiatrist.
Wow.
And gosh, look where I ended up. So it's
still such a big psychological, that's what I was going to ask you. Do you ever draw on that? Do you find that helpful in maybe like identifying red flags in consultation?
Absolutely, 100%. Now, the first thing to talk about is body dysmorphic disorder, right?
There's a lot of it, right?
There's a lot of it, but remember that's a psychiatric diagnosis, right? So you've got to have, and there's usually a whole list of requirements. You've got to have a proper assessment, etc., etc. So that is full-blown BDD. Let's look at kind of the gray area is dysmorphic traits,
right?
Which most of us have.
Right, yes.
There's that one thing or those two things that you look at in the mirror.
I've got it with my face. I don't know so much my body. I definitely got it with my face.
100%, right? And where you differentiate whether it becomes a full-blown pathology is really an unrealistic preoccupation with it, even though it is, in the grand scheme of things, quite minor. And that's where you have to kind of step in, because you have duty of care. And the patient may not necessarily know that they have it or that they have these traits, but you help them to unpack.
Right.
And always have a good referral network. Usually psychologists, and you can break it down very, very gently in a way that you're not diagnosing a patient where the diagnosis becomes a little bit of like a personal threat.
Yeah.
So there are
it's
very
a delicate
gentle
subject,
ways. It's incredibly delicate.
Are there patients that you have refused to treat?
There have been very few, and in kind of 13, 14 years of aesthetics, I'd say that there are probably 2 patients that I've kind of like turned down because you wouldn't be able to meet their expectation. But there were also patients who were kind of like doctor shopping, not really happy with treatments.
Yeah, they didn't really know what they wanted.
Yes, that kind of thing.
When we look at people like Jocelyn Wilderstein, do you think that there should be stricter psychological screening for certain, probably more surgeries than treatments, right?
Absolutely. I think the more invasive, the more permanently anatomically altering, so that would be the surgeries, etc., should have tighter controls. I will say that the plastic surgeons have it ingrained in them before they perform a procedure. It's because of their specialty that we have the cooling off period, which we've kind of borrowed in aesthetic medicine. So we spoke about threads, right?
Yes.
If somebody's wanting to have threads, I actually use that. So we do a first consultation and then we do a second consultation.
Yeah.
And one of which must be face to face. So the first one is usually, sometimes it's just
and
information.
When we're talking threads, explain for anyone that doesn't understand what threads are.
Okay. So threads, you get permanent ones, semi-permanent, ones that break down.
Yep.
So that's the ones that
that's
we
what
use.
I had.
Yeah, that's what you had. And they stimulate collagen. There's about 4 or 5 different types available on the market. So the one I use is a PDO, which is, it basically comes from a suture that dissolves.
Yes.
So,
are they the same as mint threads?
Yeah, so Mint is a brand.
Right.
Of PDO threads.
Yep.
Yeah, and there are quite a few good ones that are available. So invented by Korean plastic surgeons as a non-surgical facelift. It does get a lot of bad press, understandably, but I mean, I teach it and train it. We do it. We perform them in our clinic. The biggest issue is patient selection. And there are more people who are not suitable to have threads than those that are.
Really?
Absolutely.
Why would a person not be suitable for threads?
If you're looking at a degree of ptotic tissue, so that means they have got bony resorption. As we age, that happens to all of us. They have got a lot of kind of what we call malar descent. They've got the skin quality is really, really not that good.
Right, okay.
And threads have their limitation.
I see.
So if you're not going to be able to lift and reposition the tissue to only 1.5 centimeters, that's the aim.
Right.
You're not going to get a good result.
They're not going to get the results. Yeah. Do you think, I know we were talking about this earlier as well, do you think that this kind of generation, this society now has created kind of a lot of expectations that are not always easy for you guys to deliver?
Absolutely. You know, you've got the one positive about that, I would say, is the Korean glass skin effect, right? And that's not necessarily a bad thing because it pushes patients in the direction of skin health. You're not going to get Korean glass skin with Botox and filler. You're going to get it with regenerative treatments in the skin. You're going to get it with resurfacing treatments in the skin. And when patients see that skin quality is looking a lot better, then it kind of moves them a little bit away from, you know, the kind of traditional treatments we would do before, like toxin and filler.
Yeah.
So I think in a way it is a good thing. Where we have a little bit of a problem is really where people kind of promote products or they promote modalities that have no clinical or research basis to it whatsoever. And that we're now sitting in the danger zone.
Yeah, they're making the claims as well, aren't they? There's a lot of that.
Absolutely.
Yeah.
So if a product doesn't have, doesn't come from a reputable manufacturer, even if they have their own clinical papers, their own internal research papers, which a lot of companies will let you have to check the efficacy or the effectiveness, which for our viewers is, does it do what it says on the box? Have you worked out what the side effect profile is in immediate, short-term, medium-term, long-term? How many cases have you done? How long has it been in production? So those are the kinds of things that we have to look at because we kind of the filtering mechanism. Instead of going, oh, we saw this on TikTok or on socials. Oh, it looks great. It's amazing. So let's bring it into clinic.
Yeah.
Absolutely not.
Yeah. So let's get into ethics and industry regulations. Okay. UK regulations. I've been dying to talk to you about this because I feel that, I feel that there's a bit of confusion at the moment about who is allowed to do injectables because I, for one, thought that there was a new law that passed in 2022 that was banning non-medics from performing injectables. But then I found out that wasn't actually the case. It was a Health and Care Act 2022. But does that mean that non-medics can still inject Botox and fillers?
Yes, absolutely.
There's still cosmetic cowboys out there.
Absolutely. It's incredibly concerning. I think the legislation in Scotland has now, it will come into effect. I think it's around 2027,
right?
Where there's now this transition period. Look, it's about safety. And I will say that, let's start with toxin. In the United Kingdom, it is a prescription-only medicine. It has got cosmetic uses, it's got medical uses. You need to do a face-to-face consultation with the patient beforehand, and it needs to be prescribed. When it is prescribed, it's prescribed for a particular patient. You do the treatment that you need for the patient, and then it's kind of done.
And it's coming from a proper manufacturer.
Absolutely. This is now taking us on a little bit of a tangent, where you're having the ability to purchase these products online. They often counterfeit. You don't know. There's counterfeit everything.
Yeah.
Let me just tell you, there's counterfeit fillers we found in our own brand. There is counterfeit toxin. We have found counterfeit Rejuran. And they literally spoke
already,
about it.
But it's brand new.
Absolutely. It's brand new here, but it's been around for about 10 years. It's brand new in Europe. Yeah.
Got you.
There's, and here's the sad reality is like, if I put up a post on Instagram of a before and after, I will be flooded with messages from wholesalers, pharmacies, how much are you paying for Botox? Because we can give it for this amount. It's an absolute minefield. So it's not just on the practitioner level. It's also just like kind of not just non-medics injecting. It seems like on the periphery, everyone's in on the bandwagon because everyone thinks
it's a multi-billion-dollar industry.
Yeah.
Like everyone's trying to make their buck, aren't they?
Absolutely. But at whose cost?
It's so dangerous, isn't it? I can't believe that people would even go to a beautician to get their Botox done.
We, if there is a framework for them by way of education.
But what level? So
degree,
NVQ7 is allowed to do injectables, or is that still iffy to you?
I've seen the curriculum of the NVQ7. It's not robust and it's not thorough enough. I do believe that there should be a dedicated degree program.
Yeah.
And I think that might be a good way to kind of bridge the gap, because ultimately you're learning a lot more than you would learn on a one-day course.
Yeah. Yeah.
So
I have a horror story, actually, not a horror story as opposed to me, but I was getting my lashes done once by a girl who was literally it was the worst lash job I've ever done. It wasn't my regular lash girl. I had to go to someone else. She was really heavy-handed. She gave me a headache because she was leaning on my forehead. And I was horrified to hear that she was doing a 2-day injectable course after that the next day. And she was heavy-handed. Like, it's just shocking to me.
Yeah, it is. I suppose there is an overlap between it being cosmetic, but it's
medical.
It's still driven by medicine.
Yeah. When it comes to the clinic, is there growing pressure on clinic owners to meet targets?
So we're a little bit different, and I think it's primarily because we are all kind of independent practitioners that work in the clinic. We are all practitioners and professionals in our own right. There are clinics that have, kind of sales targets or figures targets, but we don't necessarily implement those kind of very much.
Right.
The reason is that I feel you shouldn't really sort of incentivize it. For the staff, because it doesn't sit very well with me. Let me just put it that way. I'm kind of skirting around it, right? Yeah. Because it's kind of like you're coming in for a treatment. I don't necessarily want the other doctors in the clinic or our therapist to basically go, you need this, and this, and kind of upsell. Because, upsell's a little... There's a delicate way to do it. And obviously you can recommend products or you can recommend other treatments, but you don't want to do it in a very cringy way.
And you've worked at a few different clinics. Is it something that you found that clinics do?
I find that when clinics are doctor owned, I find that the foot is not on the gas as much in the clinics I've worked at. The clinics where I have worked, where it's owned by business people, it's like, oh no, it's like it's foot to the floor. Yeah. It's,
it's a cattle market.
Yeah. Why haven't you sold skincare with this injectable treatment? Why this, why that? And I think the medically led clinics, the doctor-owned, doctor-led clinics, it's kind of like, if it's not needed, what are we doing? Yeah.
That's nice. That's good to know. Okay, let's talk about clinical approach and treatment philosophy. Your work leans towards, and I can say I'm actually I've actually had a treatment from Dr. Zunaid, so I am speaking personally now. Your work leans towards natural results. How do you get these type of results, and what does natural mean in aesthetics?
Okay.
Because there's such a connotation that when you go and get needles stuck in your face, I hear it from so many people. People always saying to me, why are you getting this done? Why are you getting that done? Because people think you're going to look fake all the time.
So previously, what we had at our disposal was essentially toxin and filler. We didn't have as much as we have now.
There's so much now,
right?
Isn't there?
And we didn't have the energy-based devices with the amazing technologies that we have now. We didn't have polynucleotides. We didn't have that many biostimulators, or we did actually have them, but a lot of people were scared of using them, right? And now what you find is the shift, and the positive shift where we just like, oh, thank goodness it's happened, is skin health. Now, natural is actually easy for me. Unnatural is quite difficult to do. So let's start with, what is it that you are doing? Are you restoring volume? Are you replacing volume? Or are you essentially creating a structure that shouldn't be there anatomically for the patient? The easiest example is really the cheeks.
Yes.
Right. Many anatomical components to the cheeks. And you touched on this in the cab, and I was saving it, right?
Go on.
So I was, I don't hide and kind of anything, right? So in 2021, the year after the pandemic, I had put on a lot of weight during lockdown.
That's when I met you, 2020.
Yeah. And I put on a lot of weight. We have heart disease in my family. My triglycerides were off the charts, whatever, satisfied the criteria to have the GLP-1 injections. I was on it for 10 months, lost a fair bit of weight, but I did lose quite a bit here, right? And the treatment I had was to replace the volume I lost. Whereas if I was actually going to start creating these lateral cheeks, you know, these kind of like cat cheeks, something that's not meant to be there, I think that's when you really tip the balance. And that's when, and patients may like it initially, but then what you find is, you know, that work colleagues, husbands, partners, children, you know, might kind of give them a bit of a negative reaction, and then the patients don't really like it. And I still stand by my guns. I hate dissolving filler. We do it right.
Yeah.
You know, that's a kind of thing, you know, in an emergency situation, that's if you blocked a blood vessel, you've got a vascular occlusion, that's completely different. But you don't necessarily, it's not a try before you buy. Yeah. You know, these are medical procedures. So, you know, and it takes time to sit with the patient. We've got, I call it like our internal portfolio. So we've got pictures that we only show in clinic. We don't show on social media. So when patients sit with us, we're like, okay, so this is kind of the shape of your face, and this is what I've done on this patient, and yours will look a little bit similar. So the patient can get a good understanding for what it looks like. And then you're looking at, as part of the aging process, you know, lines and wrinkles, and you can treat those without altering the structure of the patient's face. Yeah.
Yeah. What separates a technically good injector from a truly elite one, like yourself?
God. I'm gonna let the patients say if I really am, but I don't know, because sometimes I do a treatment and I'm a bit like,
you're hard on yourself.
Yeah, 100%. You absolutely have to be. And like sometimes I'll do a treatment and I'm just like, seriously, that looks amazing. Like the patient looks at me a bit funny, going like, God, you're excited. It's like, it's my lips, not yours, kind of thing. I think it's really sort of the treatment planning. Yes. It's when I say taking care of your patients, when I'm teaching, sometimes I get a little bit of like funny looks, but I think the message is really clear from me to other practitioners and injectors is like, aesthetic medicine is not an escape from the NHS. I've never worked this hard in my life. I'm telling you right now, you are on call 24/7 for the rest of your life. You are, and when you start performing and doing medical grade procedures, whatever, you're constantly looking at your phone, making sure you don't miss a patient reaching out, you don't miss an emergency, you don't miss a patient who's kind of like needs a little bit of reassurance. And I think that is what differentiates practitioners. You know, it's not an
they're
office
not all
job.
like that, though, Zunaid. I think that you are very special. How has your background across the different medicines, because you've done practice so much back in South Africa and everything, how has that influenced your decision making in aesthetics?
You really have to streamline your treatment plan. So you want to do as much as possible with as little as possible.
What does that mean?
So that means, we can do a bit of this. We can do a bit of Botox. We can do a bit of biostimulators. We can do a bit of this. We can do a bit of that. But that's great. But you're just adding to the basket of cost for the patient.
Yeah.
So when you're sitting and assessing a face, you're looking at what could you potentially do for that patient that is going to give them the impact, the result that they want, without necessarily doing, without necessarily doing like 15 different treatments. Do you know what I mean?
Yes.
So that's really where the practitioners gain the knowledge and skill, and then they just kind of like hone it into, okay, these are kind of some of the hero treatments that we're getting good results with for certain types of patients. And then and you go from there.
Yeah. Are there any trends right now in aesthetics that concern you?
I think at the moment it's people buying the weight loss medications online without proper support.
Without proper consultation.
I think that's the thing that's really concerning at the moment for me. The good thing is that patients are starting to become more wise. They're becoming to, they're starting to question things. But why this and not that? That sort of thing. So when it comes to aesthetic treatments, you find that patients will have a preconceived idea of a treatment and what it can potentially do. And that's why they come in for consultation. So you can see if it's suitable for them and see if it could possibly be done.
Yeah.
So I think the caution is really not being able to because even with the weight loss medication, I mean, we do them in clinic, but we bring the patients back, we sit with them. So
do you give them nutrition plans?
Give them nutrition plans. What's gone well?
Because that's really
difficult?
important, isn't it?
What's gone well? What did you find easy? What did you find difficult? Did you manage to eat? What did you eat? Because,
And also the amount of time that they're on them is quite important, isn't it? Because people are just kind of staying on them.
Yeah, exactly. And you shouldn't be on... Firstly, you need to have a proper weight, a BMI assessment. Then you've got to look at all of their risk factors. You've got to look at their present medical conditions. You've got to look at the treatments that they've had before, their attempts at weight loss before. You do have to ask questions about, have they had problems with eating disorders? And that's my biggest fear, because I used to work in the eating disorders unit in Johannesburg. And, I just think of some of the patients in that unit, and if they could get hold of a GLP-1, it would be absolutely catastrophic for them. Yeah. So that's what I worry about. And it's also, it gives you the time, it gives you the help, it gives you the breathing space so that you can kind of get your weight under control and keep it there. So so I would say that's my current bugbear. Yeah.
Okay, so I have to ask you about one trend. I don't even know if it's a trend, but Russian lips. How do you feel about Russian lips? This is a style of filler. You get your lips filled and they're very much shaped to, and kind of like, I can't even describe it.
It's tented upwards. So the lip, if you look at the lip anteriorly straight on, it's flat, but it's got quite high vertical height.
Yeah.
So here's the thing. Most lips are not suitable for the technique. Firstly. Secondly, it doesn't really look that good in the long run.
No, that's what I always thought. How does that last? Because it can't keep that shape, can it?
Exactly. And most of them, what you find is that it will migrate at certain points. And then it's like, then again, you're looking at dissolving it. and I really don't like dissolving fillers. Dissolving filler carries a significant amount of risk for patients by way of anaphylaxis. The dissolver that we use comes from an animal source. So we have to be really, really careful when we inject it.
And does it dissolve the person's own kind of like
collagen?
Hyaluronic acid and fats and everything.
Yeah, absolutely. Not so much fats. It's more the patient's own endogenous hyaluronic acid, and it takes a little while, depending on the dose and the placement, for your body to basically kind of reconstitute its own hyaluronic acid over time.
I think that we see a lot of that process being done with the dissolver from the cosmetic cowboys, I like to call them, which is unqualified, a 2-day course is not qualified to do injectables. And so a lot of girls you see that obviously it's cheaper, young girls. I know that, there's an age limit now. They did bring that regulation in actually, didn't they? And, if it's not injected correctly, it migrates. Is that correct?
Absolutely. And the quality of the filler is absolutely paramount. Why is the cost price of a filler to us £96, and why can I buy it for £10 online?
It's so scary.
That is,
oh my gosh.
Yeah, that is a major alarm bell. If it's too cheap, there's a reason why.
Yeah. Okay, so this question is going to lead into our next section, which I can't wait to get into. Are we seeing clinics stuck in filler-first mindset when the industry is clearly moving towards regenerative and skin? I don't know if you saw Alice Hart Davis, the MRI scans.
Yeah.
And she had 20 years worth of fillers stuck in her face. I mean, I know we've touched a little bit on filler and that it's more about skin for you. But do you think there's still too many people just doing filler and not getting into polynucleotides and all this stuff, which we are going to talk about in a minute?
Okay, so let's go way back, right? Filler was taught to us, or rather presented, in a way that you inject it, you get the desired result, and it lasts for a certain amount of time, and you inject more. And once that duration is gone, as per
it disappeared. We were told it disappears.
Yeah, it disappears. And I think it was quite time and situationally specific, I think, in the industry, and also by way of research. So what you find is there's hyaluronic acid residues that were left. So people did filler on top of filler on top of filler, and hence, the 20 years worth of filler in what you saw in Alice.
Yeah.
I think the research in hyaluronic acid, in fact, I know the research in hyaluronic acid has progressed to the point where they now know that hyaluronic acid does have collagen stimulating elements within itself.
Right.
It's not the best collagen stimulator. It's quite a weak collagen stimulator, but it does it nonetheless. And here's the thing, right? I mean, this is going to become like my cliche, but like filler fills.
Yeah.
Right? If there's a void, you use filler. And we had this we called it filler fear, where we just had this massive dip in people having HA fillers and patients being really afraid of it, that it was going to not necessarily replace volume, but that it was actually going to immediately distort them.
When was this?
The
recently?
Last few years. Yeah.
100%,
absolutely 100%. And people kind of, I didn't see much of it, but there was an influx of patients in a lot of clinics, friends, clinics, colleagues, clinics that I know, wanting to have their filler dissolved, thinking that it you potentially going to be harmful.
Maybe it was because of Alice and her story.
Could be, yeah. But, you now have filler that is, I wouldn't say it's coming back into fashion. It's kind of never really left, but you're now having it as part of a wider treatment plan. So now you're like, okay, fine. So somebody's been on a GLP-1, they've lost a lot of weight, they've gotten to their goal weight, and now they're looking at the volume that is essentially been lost. So now you've got so much more at your disposal, so many different modalities at your disposal, and you'd probably use filler to replace the deep volume that they've lost, and now you can go with your polynucleotides or with your collagen stimulators. So I think it's now not necessary. Phila's now no longer the only child. It's kind of like part of a family.
Yeah.
If that makes sense.
Yeah. Absolutely. So we're going to get into regenerative treatments and innovations now. And you are obviously on your tour, your launch tour with Vivacy. Now tell me a little bit about your role. You're the key opinion leader for Vivacy. Yes. So tell us a little bit about that.
Okay. So the term, I don't know, it sounds a little wanky, to be honest. I think the correct term for it, I mean, it's a term that's been used in kind of the medical industry for many years. It's a little too bougie for me, if I'm quite honest. Yeah, I think I prefer the term clinical product specialist,
right?
Because the reason why I was asked to join Vivacy was, as a trainer, is because the first fella I trained on in South Africa was Stillage, which is a Vivacy product. And myself and all the other key opinion leaders nationally and internationally, we kind of use it exclusively in our clinics because we know how it's made, we know the safety profile, we know who to contact if anything hits the fan, even for us as practitioners. So it's, clinical safety and efficacy is definitely there. So that role has now expanded because Vivacy has now got the license for Rejuran in the UK and in Europe. So I have been doing polynucleotides for quite a number of years, and I've used quite a number of brands, and Rejuran has always kind of been in the periphery. So a lot of countries have had it. In fact, yesterday you're looking at Australia that has had it way longer than we have, so they've got more experience with this brand.
Have we just got Rejuran? Because I know you had your UK launch yesterday, which looked so beautiful. I was looking at all your stories on it, and so many of the practitioners that were there watching you on stage, they were all like putting you on their stories how much they love you.
Thank you.
Everyone loves you.
You've got to transfer skill at those events, so you've got to give a take home, you've got to give a clinical pearl, you've got to say, listen, this is what I did and I really cocked it up, or I didn't explain the swelling to the patient and this is basically what happened, this is how we remedied it, because that's kind of how we learn in aesthetic medicine. So when the license was acquired, so this was around October, we went to Korea in October, so from about November we had the official legit stock that was coming through, and then we started doing our cases and things like that, and then so Vivacy's got the license not just for the UK but for the whole of kind of Western Europe.
Right.
There are some countries that have had it before, for example, but it's good because they use the distribution channels. Of course, they use the MedEd, the medical education channels, and of course, it's about teaching practitioners and also educating the public.
Yeah.
So it's got very, very good efficacy. It's a very good, well thought out, well constructed polynucleotide.
And you're training practitioners in Europe, all over Europe, using these polynucleotides.
Yes.
What makes these polynucleotides better or different from other ones that you may have used or other clinics use?
So there's a little bit of a differentiation. So let's get a little bit technical, right?
Okay. Let's do it.
The first hint of polynucleotides we probably had about 8 years ago.
Yeah.
And this was a product it was a mesotherapy product. So it was used for microneedling. And I remember the first one that because I teach for a skin company as well, peels and microneedling, mesotherapy, that sort of thing. And I do teach the therapists the medical grade kind of facial components, right? So we got this and they said it was salmon sperm, and I was like, what? And we were all like, oh God, no, like, what's that? What on earth? Anyway, and you do the whole like, oh, what next? That kind of thing. And that was sodium DNA. And those were tiny nano little fragments that was for superficial use with microneedling. And then it evolved into what I'd like to think, let's kind of go there in the evolution of polynucleotides, right? So then you had PDRNs, which is polydeoxyribonucleic acid, which are those little bits of DNA that you saw in the sodium DNA. These are longer chains,
right?
And they are a slightly heavier molecular weight. Then through the evolution, they
Are they
still have their
injected as
place.
well?
They are some that can be injected, but they can also be used topically.
Topically, yeah, because there's a lot of skincare with that in right now as well.
And then you've got PN, or true polynucleotide. And what that is a much heavier molecule, a much higher dose. So it kind of milligrams per mole. So that's significantly higher. And you've got much longer chains of the polynucleotides, which are basically the fragments of DNA are significantly longer. And what makes Rejuran different is that is almost embedded in like a scaffold. So when you take the Rejuran and you kind of like inject it out onto a slide and you stain it and you look at it through a microscope, it's almost like a lattice, it's like a scaffold, which means it persists when you inject it, it persists in the tissue, it stays in the tissue for longer. You have more contact time in the cellular layers that need it for healing and repair. And so what subsequently happens is that you tend to see results that are a little bit better and a little bit quicker.
Right. And so that's what makes Rejuran different.
Yeah.
And where would you... So I had polynucleotides. I had it under my eyes. Let me show I brought a photo for you, actually, because it made such a difference to my life. I had, it's my Indian heritage, right? I had super dark circles under my eyes my whole life. And then I did... Can you see? I did the polynucleotides under my eyes. I also did carboxy as well. So that wasn't just the polynucleotides. I did the carboxy too. Totally changed my under eye circles.
Amazing. That's kind of the result that you would expect with it. Now, in fact, when I presented yesterday, I presented the eye cases. And here's the interesting thing. So we looked at the polynucleotide treatments as a whole that we had from the time that we started Edition Clinic, which was September 23.
Yes.
Until now. And I was like, I asked our clinic manager, just do a quick report and, let's just have a look and see. And interestingly, 7 out of 10 treatments performed using polynucleotides were for the under eye area only.
Really?
Yeah, in our clinic. And that's very, very interesting because it's a notoriously difficult area to treat. It's very, very challenging. So you've got lots of different pathologies that people see there. It's the fine lines and wrinkles, the crepiness. Of course,
the dark circles.
Fitzpatrick 4, your darker skin types, the darker circles. So it's kind of, I don't necessarily want to say it's a one size fits all, but it does, because it's a healing and repair element to it. It really, really does help to treat a lot of those pathologies that we see. So in the presentation that I did yesterday, I presented the eye cases. Now, Rejuran has a product that's literally called Rejuran Eye.
Right.
That is used for the periocular
and it's
region.
different than they're two separate.
Yeah, so they're three different ones, 3 different products that you use. You can use them interchangeably, but essentially I presented on the eye one. So we were given, of course, the products. We had to do our case studies on the patients, and I wanted to have quite a spread of patients from all across the Fitzpatrick spectrum, because that's what I see in clinic and that's what practitioners are going to see. So we did a very, very quick report on our software, and from the time that we opened with our polynucleotide treatments, 7 out of 10 patients were after treatments underneath the eyes.
Right.
And
for different types of things than me, like wrinkles and stuff. Yeah.
So for some patients, it was kind of like the hashtag lines, the wrinkles. For some patients, it's kind of the ones that sit just underneath here. It's also kind of patients, there's a fair bit of patients who don't like to have Botox around the eyes because they feel that it kind of prevents movement there. Yeah. And then the cheek muscle slightly overworks. It changes expression a bit too much. But I don't want to say that the polynucleotides are like a one size fits all, but they have a multitude of benefits because they work and heal and repair quite a few different cell types within the layers of the skin where it's injected. Yeah. So that therefore it does give very, very good results. And of course, combination. So you had it with carboxy, great. I do it often with peels. I do it often with radiofrequency microneedling around the eyes. So there's quite a few different things that practitioners can kind of like stitch together in terms of using the polys.
This regenerative medicine, it's just, you must be loving it because you love the natural look. Like I came to you and I'd never heard of regenerative treatments. I'd never heard of Profilo. I'd never heard of skin boosters. And that's what you treated me with. You gave me Profilo. And I loved it because in all the years, like I've been doing treatments for a very, very long time. I lived in LA and that's where I started doing treatments. But I've only ever really had filler, I think 3 times because I never really liked it. And also it just kind of wore off and I thought it's kind of addictive. Like you have it and, you know, and you look really, face looks full and pretty and then it just wears off and you're going back and getting it again. So I never got it that much. So when you did introduced me to Profilo, I was like, this is great. My skin feels so soft. It looks amazing, but I haven't changed the structure of my face.
Absolutely.
That's what I loved about it. Like a skin booster's like one of your number one treatments. Is that what you do a lot of?
Absolutely. It's such a massive shift in what patients really want, and patients want the skin quality improvement that, you know, that they probably didn't know about 10 years ago, didn't know that existed 10 years ago, even though the skin boosters were around at the time, because, you know, we were very filler driven. And now it's kind of like, okay, so now we know a lot more about skin health. We know a lot more about how we can improve the quality, the tone, the texture of our skin without necessarily altering the structure. So you've got your biostimulators and then you've got your bioregenerators.
Yes. So tell me the difference, because I want you to talk us through everything to do with regenerative treatments, because I think it's very confusing for us. So tell me the difference between polynucleotides, exosomes, and skin boosters.
Right. So skin boosters, more often than not, contain hyaluronic acid as the main or dominant element.
But it's not the same hyaluronic acid as in the fillers, right?
Exactly. So you're looking at, so in fillers, we have cross-linked or reticulated hyaluronic acid. So that hyaluronic acid in a traditional filler is meant to be injected in a certain depth, which is usually a lot deeper, right? For example, so they make special ones. You'll get a special kind for lips. You'll get a special kind for cheeks. You'll get a special kind, kind of for fine lines and wrinkles, right? In a skin booster, and there's so many different types, and we're going to use that term a little bit loosely, right?
Okay.
Skin booster, because technically it is a trademark term.
Right. By
to
who?
Galderma.
Oh,
Yes. Yeah.
I see. I never knew that.
Yeah. So it essentially contains, and the product which is trademarked is a hyaluronic acid based product. And it's been around for ages. It was probably one of the first skin boosters. I mean,
When?
you know,
How long?
we're talking, gosh, I think we're talking, I stand corrected because I mean, I don't I teach for that brand. I think it's been around 15 years plus.
Yes. Well, when I was looking into like regenerative, all of this kind of stuff, as well as like soft wave and that, it has kind of been around for 15 years. It's like we've just cottoned on to it, you know.
Yes, because we've had that shift in patient demand. So the skin boosters would be hyaluronic acid based. You find that each company will make it a little bit differently. So some might add other elements to it, vitamins, we've got minerals, we've got amino acids. You've got some will even do different molecular weights of hyaluronic acid. So you got 2 or 3 different types because it would hit at different layers in the skin. Some would be for topical application only, but I think for the purposes of the skin booster chat, these are the ones that are superficially injected into the skin. And they make them really kind of clever, and each kind of brand will have a skin booster in their range, and it will have its USP. So, but it's primarily hyaluronic acid based.
Right.
Then we're looking at the biostimulators. Now, the biostimulators have also been around for quite a while, and those have been seriously ramped up as well. So they're two.
This is exosomes, right?
No. This is biostimulators. We're going to get to,
we're
gonna get to the exosomes, right? So the biostimulators are the ones that usually you inject or you implant something that is essentially a foreign body.
Right.
And it relies on
threads.
That's
Okay.
a biostimulatory component. So threads is an example. You're looking at sculpture.
Yes.
You're
I
looking
had sculpture
at,
once.
You're looking at Radies. You're looking at Harmonica. You're looking at Novuma. These are some of the brands that are out there. This is implantation of a biostimulatory element. So in threads, it's polydioxanone. In Radies, in Harmonica, in Novuma, it's CAHA or calcium hydroxyapatite.
Right.
And in Sculptra and Julane, Linenza, those are poly-L-lactic acid or poly-D-lactic acid, right?
Right.
So these stimulate collagen by way of an inflammatory process. So it's injected, you trigger an inflammatory pathway, and then that triggers collagen and elastin to be produced. Right? Do
they fill as well?
They have, the filling effect that they have is not primary.
Right.
It doesn't do deep volumetric work, but essentially the filling effect you get is from the superficial formation of collagen in the superficial layers of the skin. So that's kind of the biostimulators. Now, exosomes. Exosomes are tiny, tiny nanoparticles. They are they have a paracrine effect. So what they do is they enhance cellular communication, right? Now,
the messengers.
Yes. Exosomes usually triggers a huge argument.
Really?
Oh gosh, yes. Is animal better than human, better than plant, better than synthetic? And each company will have, of course, their own construction and manufacture, their own research, etc., etc. But to my understanding, and the exosomes that we use in clinic is not for injection. They're for superficial applications.
Do you use microneedling?
Because microneedling, we use dermastamping with them as well. We often do like radiofrequency microneedling, and we use that as, we apply that topically afterwards. We can do that. I often do it after CO2 laser as well. You take a vial, you reconstitute it, and you apply it until it's fully absorbed. Why? Because we want that intercellular communication to work really, really well. I am aware that there are injectable versions of it, but
yes, no,
I'm not sure.
You're not, because we don't do it here, right? So they only inject exosomes in the States. Why is that, and why don't you agree with injecting them?
I would really have to see how the molecules of the exosomes are constructed to see if it is truly exosomes or is it just not sodium DNA or PDRN that is being labeled as exosomes. Do you know what I mean? So I would say I've heard of the product, but I've not seen it. I've not delved into it. So I'm probably as in the dark as you are.
You're happy with the results you get the way you use exosomes? Yeah.
Because when they applied and they use topically, you do actually get quite nice results with it.
And they boost, what are they going to boost? Collagen?
They boost cellular repair. So they work from the outside in.
Yes.
So they get your cells to work, especially the cells in the superficial layers of the epidermis. They get them to work a lot better, a lot faster, a lot more efficiently.
Nice. So you're going to get that lovely strengthening boost and glassy skin and just that glow.
Yeah. And if you're looking at like a vial of exosomes, I mean, you're looking at least, 5 million, 10 million plus concentration. So it's very, very punchy. And you get ones that you could use everywhere, skin and hair. And then you get some brands that have like specific ones where, they have specific ones for skin, they have specific ones for hair. Yeah. For hair regeneration.
Then we've got the energy devices, the regenerative or the biostimulators like the HIFU, the soft wave. How do you feel about those, the big machines? I know you spoke a little bit about the RF microneedling.
Love it.
Do you?
Love it, yeah. It's with energy-based devices, of course your consultation is super important, and choosing which one is kind of the right one for the patients. when it comes to, and they all, companies throw a lot of money behind research and development in particularly their devices that they're going to be bringing to market. And it's really about which one you feel comfortable with in terms of bringing it into your practice by way of your patient population, your patient demographic. It's incredibly seductive.
Really?
It is like, you
want them all, don't
to a conference just like, oh my God, it's so shiny.
I could imagine.
And it depends on, it really, really does depend on what you want to bring to
what
clinic.
have you got in addition?
So we have a CO2 laser. We also have a CO2 FemiLift, which is used for vaginal tightening. We have radiofrequency microneedling. The brand is Morpheus.
Yes.
We have just good old fashioned radiofrequency.
Yes.
We have IPL. We have ND-YAG. We have Q-switched ND-YAG. We are a training partner with Linton Lasers UK, so we have a lot of their lasers in our clinic. So we have their IPL system, we have their Q-switch laser. So that Q-switch is essentially what you'd use for things like tattoo removal, veins, vascular. We also have a laser hair removal, Alexandrite laser for skin of color and thicker hair.
Yes.
Yeah, that doesn't burn the skin.
Yeah, when I got all my hair lasered off my body years and years ago, and they just couldn't treat black skin.
Yeah. And the technology is so much better and safer because, darker skin is a complete misnomer. Darker skin is so sensitive. You can get it wrong so quickly. So these machines add that element of safety to it. And then we've also just recently acquired a machine called the Focus Dual, which is radiofrequency microneedling, one handpiece, and then the other handpiece is HIFU. So, but it's straight line HIFU. So the technology is actually quite nice.
What's straight line HIFU?
So some of the older HIFU machines is kind of the ultrasound energy is fired almost like in an arc.
Right.
So it almost like if you've got the handpiece and if you're kind of applying it to the skin, the energy converges in a point and creates a little bit of a thermal, let's call it burn for lack of a better terminology.
It burns.
Right? Yeah.
I've had it done.
Right.
God,
so
with
this machine, as the ultrasound energy comes out of the handpiece, it comes down in straight line, so it covers a larger surface area.
I see.
And
a bit like
makes
Softwave.
it more,
So they've upped their game. HIFU's upped their game because of Softwave.
Absolutely. And it still has its place. It definitely has its place. You will also find a subset of patients who just don't like the idea of injectables and they'd much rather have an energy-based treatment instead.
I had great results with HIFU. And it lasted. Obviously, you're having a course of it I had Softwave and it's just one. I mean, I could have had more if I wanted to. But HIFU, I had a course of 3. So maybe that's why I got such great results. And they lasted for I just had the biggest boost of collagen. Like, it was almost like I'd had injectables, almost like I'd had fillers, but really subtle ones.
Absolutely. And it's, and this is where your patient education comes in because the results are not instant. And in fact, when I had the first HIFU session on the same machine, it felt a little bit like puffy. And I was like, okay, just half of the course, relax. And then when when I got the nice tightening effect, even after just one session, I was like, okay, because I like to experience it for myself.
Yeah, I can imagine.
And we have exactly the same treatments in clinic as our patients do. So it's important for us to understand what the patients feel and experience.
How do you, you've just mentioned all the machines you've got, and then on top of that, you've got all of your injectables and your regenerative treatments. How do you decide on what to use? Obviously, I know that you look at the patients,
We also ask patients, patients are a big part of the treatment plan. And there's some patients who will just, oh God, I do love a peel. I have that peeling effect. It's like that new skin. And then there's some patients going, oh God, are you joking? I can't think of anything worse. Yeah. Where will I put my face for a week? and then you
of course, because some things don't have HIFU's got no downtime whatsoever. Absolutely. But then you have a peel and...
Yeah. And it also depends on what it is that you're treating. And when you examine the patients, for example, treatment of pigment, you've got to give it a diagnosis. It's not just pigmentation. Pigmentation is a broad generic term. What kind of pigmentation? Where's the pigment sitting? Why is the pigment sitting there? What made it sit there?
It's true, because I've got a scar right here and it looks the same as my pigmentation marks from sun.
Yeah, absolutely. And that's post-inflammatory hyperpigmentation. And the way I would treat that would be different if, for example, if you came in and you had like melasmic deposits. Do you see what I mean? The treatment would be almost entirely different.
What do you use for? Is it IPL? Is it laser? What do you use for pigmentation?
We start off with, I like combination treatments for pigmentation with patients. We generally start off with IPL. IPL's lovely because what it does is that intense, that's what it stands for, is intense pulse light. So that light is at a very particular wavelength. So you've got Caucasian skin have a wavelength, and then you've got slightly darker skin.
So you're altering
has a less intense wavelength, right? Yeah. Because darker skin is more likely to burn, and so what it does is when the light is basically fired, it almost like it shatters the pigment. Right. And that allows your body to naturally bring it up to the upper layers of the epidermis, where it just kind of flakes off. Right. So we tell patients, when you're having a treatment with IPL for pigmentation, it's going to probably look darker before it flakes off.
Before it gets better. Yeah.
And no scrubbing, no nothing. You just let it happen.
Yeah.
Just let it happen.
Do its thing.
Absolutely.
Yeah.
It has a few caveats to it, whereby you can't do it if the patient's been in direct sunlight, for example. You can't do it if they've got fake tan on. So there must be absolutely nothing that alters the surface of the skin when that IPL probe makes contact. So no fake tan, no tanning. God, please, no sunbeds, none of that, no melanotan, absolutely nothing like that. So we tend to pause a little bit for our pigmentation
that's a
patients.
tricky treatment.
Yeah. So we tend to pause in the summer months because our patients, they're
everyone's going to catch the sun.
Everyone's going to catch the sun. SPF 50, and it's quite nice. You just eliminate the heavy UVB and the kind of UVA element to an extent in the autumn and the winter, and you use the grey skies to your advantage.
Yeah, do you do that with those peels patients as well?
We tend to do that with peels. A lot of the superficial peels that we do, for example, our PRX therapy is non-photosensitizing. So
really?
Yeah.
Wow.
So you can do it, and the downtime is practically none. You might have a little bit of superficial flaking, but that's essentially it. Yeah. And that's where companies start getting really inventive, and that makes me pay attention, because I'm like, if you're spending that amount of money and time in kind of conceptualizing and manufacturing a product, are you making a false claim, or do you have the science to back it up? And if they do, I'm like, yeah, okay, you're kind of onto something here.
Yeah. So that it's crazy, all this stuff now that's compared to what it was, I'm sure, when you first started. Okay, I could literally talk. Okay, before we get off of this topic, is there a favorite treatment that you have, or is it really just client based? Like, you couldn't have a favorite one?
Do you know what this is the strangest thing? Is the more treatments you learn how to do, the more things, the more how does it go? The more strings you add to your bow. The thing for me, I think, that gives me the most gratification, it's still lip filler.
Really?
Yeah, like it's the result that you get. Like I'm the queen of a 0.5 ml, honey. Like,
you did my lips, and he would not give me more than 0.5 ml. I was like, "Are you sure? I think I need more." He was like, "No."
You probably, how do I put it? The result you get from a 0.5 ml, especially if your patients never had lip filler before, they might have had a bit of a disaster. It's really lovely and natural. And that again ties in with the natural ethos, where it's like, I don't want big lips.
Yes.
Is it going to migrate? Is it do you know what I mean?
And you're not going to have those migration problems, are you, with half a mil either?
And you put in a 0.5, you give it a lovely crisp shape. You don't volumize it too much. You're just kind of giving it a little bit of contour. You're just kind of like enhancing it just ever so subtly. You can have another half a mil in a few months.
Yes, that's what you said to me.
Once it settles and once it integrates. But yeah, and I mean, sometimes it's just like you do a good set of lips and you're like,
mic drop. And also the difference it makes to women and also men. I saw a guy, you did a before and after on your Instagram, and he had a beard and everything, and it was, you'd never guess that he'd had lip filler done, but it just made such a subtle difference.
Absolutely. And he had lip filler before, like 5 or 6 years previously, and there was a little bit of asymmetry one side compared to the other. In male patients, you probably do about a 0.6, 0.7, but even then, it's still kind of under 1.
So that's your favorite. One of your favorites, I suppose.
Definitely.
Yeah. Okay, let's get into running a modern aesthetic clinic, which you do now. Now, Edition Clinic has been open for nearly 2 years now. What's the biggest challenge for you as a clinic owner that you didn't anticipate at the start?
It's the admin.
Ah, really?
It's the admin. So we, when we open, I mean, obviously we were going to be CQC, Care Quality Commission registered, because we do a lot of regulated activities in the clinic. And it's important to have, because the regulation, I mean, not that we wouldn't, but it keeps everyone on their toes, really.
Right.
But it's the admin. And it's not, and when I say admin, it's not patient admin. So it's not doing notes, it's not writing prescriptions, it's not looking at the diary, making sure that, you've ordered your threads and you've got enough polys because you've got, your patients are coming in for their second and third treatments. It's kind of like nuts and bolts, that kind of thing. So like this evening after this, I've got a couple of patients that I can't put in anywhere else. And then after that, I'm sitting at my home computer doing spreadsheets. And that's what, because tomorrow's month end, girls need to be paid.
Yeah.
So yeah,
it's a lot, isn't it?
It is. But, I would say, factor that in if you're thinking, even if you're a one-man show, always factor that in. And which I didn't do, and which I slightly regret now, is have dedicated cut-off admin time. You don't have to do it in the clinic. You can do it on your laptop at home, nice and relaxed, but factor that time in, because if you don't, as a kind of new clinic owner, it's like you're going to forget to pay HMRC, you're going to forget to pay your PAYE, you're going to forget all of this, and that could get you into a little bit of trouble. Yeah.
And what separates a high-performing clinic from one that's just getting by?
It's the human potential. I teach all over the UK, go into clinics to do in-clinic training, and you find really efficient one-man shows. You find them in like the most lovely places. It's in places kind of like you find them in the loveliest of places. You'll find it in Carmarthen in Wales.
Really?
Yeah, you'll find it, and you go into the clinic, and you'll get in the morning, and you're starting your teaching day, and it's like, it smells of bleach, and it's absolutely immaculate, but it's the human potential that drives the clinic.
Yeah.
And you have to be on it, not just from the sales and marketing perspective. Social media is really, really important. I didn't think that it was. It used to be like,
it is a big part of everyone's business, isn't it, now?
It's essentially your portfolio. So I think it's the team that works together. It's kind of like, make sure you don't get fatigued. It's very easy. It's a procedural specialty. You're on, it's hands busy, standing up, leaning over patients all the time. It's busy.
Yeah.
So I think it's really kind of what you put into it is really what you're going to get out of it. Yeah.
Now, talking of training, education and industry standards, a big part of your work and what you do is training and mentoring practitioners. So you're not just like in the industry, you're shaping it. So what's the most common gap you see in practitioners coming through training today?
I would say that practitioners need to just approach aesthetics with open eyes. You see practitioners who would come in and start doing aesthetics as a little bit of a side hustle, and that's absolutely fine, but consistency is key. I don't like using terms like the market is saturated and blah blah. I don't know that. I haven't done research, to be able to say that. But what I will say is, look after your patients. The more you learn, the more you realize what you don't know and where the gaps are in your knowledge. And in aesthetics, where it's a very, very fast moving specialty. It's important to follow the science and not necessarily the trends. And of course, following your own instinct. It's kind of, I was a practitioner who was lone practitioner working on a Saturday afternoon, last patient of the day, and she had a vascular occlusion.
Wow.
And that really did help to shape me, because I'm telling you, I qualified in South Africa. I worked in township hospitals. I've seen gang fights. I've seen gunshot wounds to the chest. I've seen it all, and you become quite conditioned to it. But that day, with me standing beside that patient who lost blood flow to the middle of her face, I've never been so scared in my entire life. And this is working in emergency and trauma and seeing all of that. And if I didn't have the knowledge and the skill that was passed on to me on training courses as to, this is your emergency kit, this is what you put into it, this is what you make sure you have. You don't just have one vial of dissolver, you make sure you have at least 5.
Yeah.
I don't think I would be sitting here.
Yeah.
And I don't, and everything happens for a reason. And I think it's now that has shaped me in getting that across.
Which leads me into my next question of, can this field really be learned through courses alone, or does it take years of clinical exposure to get it right?
Both. The course is going to give you what you need in terms of a theoretical, often anatomical, histopathological framework. But it's really your own experience. And this is where you have to be disciplined enough to do self-directed learning and reflection. And what that is just simple things. Look at the cases that you did last week. What went well? What didn't go well? What could you improve? Did the patient reach out and say her one eyebrow was a bit higher than the other? Okay, fine. So will that change your injection pattern for that patient? Will you reduce the dose? Will you inject higher up? Those are the kinds of things. And you find that the practitioners who are quite scientific, quite clinical, are the ones who really kind of leap forward in that sense.
So the future of aesthetics. In 5 to 10 years, what do you see the field of aesthetics? Where do you see the field of aesthetics going next? And also yourself. Where do you see yourself in 5 to 10 years?
I'm happy that we are on the regenerative aesthetics bandwagon. I really, really am. I don't think that this is necessarily a trend. I really think that this is a permanent shift in the industry.
Good.
It's taking, because now we've got so much more, right? So you're going to take the bits that you need to perform a treatment or to treat a certain skin condition and kind of go from there. We're already seeing it in practice, but it's combination treatments. Now, combination treatments are a double-edged sword, because the practitioner is going to use what they have available. So do they have energy-based devices? Do they have injectables? Do they have peels? Do they have whatever they have? They're going to basically build a treatment plan around that. And that is where I think you really get the best benefit. The other side of the sword is making sure that these are safe for patients, because you can very easily overstimulate skin with treatments. So I think that's kind of where we're going. It's really such a detailed, bespoke treatment plan for the patient. And I should also tell the viewers is that we're now at a point in my clinic where your treatment plan is not going to be 1 or 2 sessions. The treatment plan is going to last you about a year, a year and a half, and you're going to have sequential treatments, and we're going to build things in here and there. And it's really going to give you the opportunity to kind of see the benefits, the incremental benefits of that regeneration or that biostimulation the whole way through. So the patient enjoys the journey as well. And they're not concerned that you're doing too much at once and that you're going to change too much. So I think, it's kind of detail-orientated, bespoke. It's drawing everything that you have in your hands and at your disposal.
Yes.
Where do I see myself? I don't know.
Doing what you're doing at the moment.
Beach somewhere, maybe.
Yeah. Having more vacations.
I do love it. I need to get a little bit better at, I think, managing my diary. Yeah. For the first time in years and years and years, I actually just booked days off where I'm just like, no.
Good for you.
Just, yeah. And I think that's kind of particularly important. I think why I enjoy it so much is because you tend to see the same patients over, and you do follow them on their life, even though they're coming in for treatment. It's the weirdest thing. You follow them on their journey. They've got grandchildren, they've got going through fertility themselves, or you'll have a patient that will send you a message saying like, I'm so sorry, you won't hear from me for a few months because I want to focus on, my fertility treatment. Or, a patient that has moved abroad and then comes back and like touches base, and it's really lovely. And there's great power in aesthetic medicine as a specialty, because you see patients more often than they see their GP. Yeah. And you do have to have like your eye on the ball, even though they might be coming in for a particular treatment. You just like, how long have you had that on you? I don't quite like the look of that. Do you know what I mean? Like, for an example, I had a patient who had an issue with blood pressure medication. I know her. She's been coming to me for years. She sat back in the chair and she was like the color of the wall. And I was like, are you okay? And she was like, oh, they changed my blood pressure medication. It makes me feel awful. And I felt her pulse, and I was like,
wow. So you're like a GP as well.
Like we're in a bit of trouble here. Yeah. So, it's and that's really part of the duty of care.
Yes. Yeah.
Perfect.
Well, thank you so much, Zunaid. This has been wonderful talking to you. Cool. Thanks for joining us.
You're very, very welcome. Thank you.
And I wish you all the luck in the world with Edition, and have lots of fun for the rest of the launch of Rejuran.
Thank you so much. I think just a few more European cities. So there's a Geneva, then there'll be a Poland at some point, and a wonderful city I've not been to called Sopot, and then France will be in September.
Wonderful.
So yeah, perfect.
Great.
Thank you.
Thank you so much for joining me today. Please, if you like the episode, share it, like it, and subscribe. See you next time.